We are live.
Okay, so good evening, everyone. So it's a great pleasure to for today's webinar, New Year updates on lung cancer treatment updates 2024. Now I would like to invite meeting convener Dr. Manish Sharma. He is a consultant and head of unit medical oncology, Postran super specialist and cancer hospital Rohtak. So it's over to you, sir.
Thank you so much. Good evening, all, uh, for joining at this evening on Sunday. And as we know that the lung cancer is the most common cancer, and there is a rapid changes in the lung cancer nowadays with the advent of all these immunotherapies and targeted therapies. And especially, we will be talking today about the EGFR mutant lung cancer. And to speak on the topic of adjuvant lung cancer in EGFR mutant NSCLC, we have Dr. Priyanshu. He is consultant and unit head at IVY Hospital, Mohali. I welcome you, Dr. Priyanshu.
Thank you, sir. Thank you very much. And a very good evening to all the participants today. So, as sir said, that lung cancer is the most common, and I would say these days, the one with the most happening, I would say cancer. So, we have moved away from chemotherapy to targeted therapy and immunotherapy. And when it comes to targeted therapy, I think EGFR mutation is the most important one in lung cancer. So I'll be discussing today reinventing adjuvant therapy in EGFR mutated early lung cancer. The slides have been provided to me by the organizers. So coming to the survival outcomes in resectable and non-small cell lung cancer. So we look at the survival, the global 5-year survival rate decreases as the stage increases in even in early lung cancer. So, lung cancer is the leading cause of cancer death, 1.8 million deaths annually, and non-small cell lung cancer represents approximately 80% of all lung cancer diagnosis, with an estimated 30% of patients presenting with resectable disease at diagnosis. So, the 5-year survival stage 1B is 65 to 75%, stage 2 50% to 70%, stage 3 8 it drops down to 30 to 45%. Next. So these days, the expert consensus recommendation on biomarker testing in metastatic and non-metastatic NSCLC in Asia, they say that for non-metastatic resectable cancer, we test for EGFR and PDL1 in resectable cases, and EGFR mutation positive, that is exon 19 deletion or L858R, and these we'll be discussing. And then EGFR mutation negative, PDL1 positive, more than 1%. These are eligible for adjuvant immunotherapy. And the third subcategory is with both EGFR mutation and PDL1 negative tumors. Next slide. So if we look at the study, which was to study the prevalence of EGFR mutation in patient with resected stage 1 to 3 non-squamous NSCLC. So presented in ASCO 23. So this study enrolled consecutive patients with surgically resected pathological stage 1A to 3B non-squamous NSCLC between March 21 and October 22 at 33 centers across Middle East, Africa, Latin America, and Asia. So if we look at the overall prevalence of EGFR mutation in early stage resectable non-squamous NSCLC was 51%. And among these, 50.5 were deletion 19, 36% were L858R, 3.3 T790, compound in 2.3%, and rest were uncommon and other mutation. So if we see EGFR mutation was 51%, which is, more than half of the patient actually had an EGFR mutation. Next. So this was again another study, presented at ASCO 23. So this study showed that this is the prevalence of. They've studied the patient who had received subsequent treatment post resection. So majority of the patients, 73.2%, had only surgical resection, while the rest received surgical resection plus RT or standard therapy. So I would say that only 46.3% patients received adjuvant systemic therapy, in stage 2 and 3 NSCLC, while if we see 73% of the two went, that is 2/3 received only surgery. Next slide. So after initial treatment, more than half of the patient with resectable NSCLC experience recurrence within 5 years. So there's a huge unmet need. 50 to 60% reoccur after surgery. So given that over half of the patient recur after curative intent surgery, there is an unmet need for improved neoadjuvant as well as adjuvant treatment option in order to improve outcomes. Next slide. So this is a classical school of thought. This was 2006 ANITA study, which and the subsequent meta-analysis which proved that adjuvant chemotherapy after surgery in stage 1B to 3A NSCLC improves disease-free survival as well as overall survival. So if we look at the curve, the pink one is the one which received chemotherapy. In this study, it was relbin plus cisplatin. So again, more than 5% disease-free survival as well as overall survival. So this was one of the first studies to show that adjuvant therapy, in this case chemotherapy, improves DFS as well as overall survival. Next slide. So after that, when the TKIs came into the picture metastatic setting, the first generation TKI were tried in the adjuvant setting too. So, but the data which was not very convincing with respect to overall survival, and in some case there were negative trials too. So this was a select study which was stage 1 to 3 EGFR mutated lung cancer. Again, erlotinib after adjuvant chemotherapy. So DFS benefit approximately 12%. Then RADIANT study, stage 1B to 3A EGFR mutated erlotinib versus placebo after adjuvant chemotherapy. Again, DFS improvement 46.4 versus 28.5 months. Then EVANS study, erlotinib versus adjuvant chemotherapy, significant DFS improvement 42.4 versus 21 months. Then adjuvant CTONG 1104 trial, geftinib versus adjuvant therapy in stage 2 to stage 3A, significant DFS improvement 28.7 versus 18 months, but no significant overall survival benefit. Then BR19 study, again stage 1B to 3A EGFR unselected population here. Geftinib versus placebo after adjuvant, no DFS or OS benefit. Next slide. So this is again the meta-analysis of these 6 randomized trials, 1860 patients and 599 with EGFR mutated. So as we see, the overall results from this meta-analysis showed that there was a 48% reduction in the risk of disease recurrence, but the overall survival benefit was not very significant. Next. So why have these data not resulted in change to clinical practice? The trials have been limited by design and size and other factors, and there was no overall survival benefit demonstrated till date. It is unclear if adjuvant EGFR TKI therapy results in cure or only delays recurrence. So there is no definitive evidence on appropriate sequencing, drug, or duration of treatment. Next. Then again, this was the landmark ADAURA study in patient with completely resected stage 1B, 2, 3A NSCLC with or without adjuvant chemotherapy. Inclusion criteria were more than 18 years, PS 0 to 1, confirmed primary non-squamous NSCLC with deletion 19 or L858R. Brain imaging, if not completed preoperatively to do that, then complete resection with negative margins and maximum interval between surgery and randomization to 10 weeks without adjuvant therapy and 26 weeks with adjuvant chemotherapy. Stratification was done with stage 1B versus 2 versus 3A, EGFR mutation DEL19 versus L858R, race Asian versus non-Asian. So they were randomized 1:1 to osimertinib 80 mg once a day and placebo. The planned treatment duration was 3 years and the treatment continued till disease recurrence, treatment completion, or discontinuation criteria were met. Follow-up until recurrence, week 12, 24, and then 24 weeks to 5 years, then yearly. And after recurrence, every 24 weeks for 5 years, then yearly. So the primary endpoint was disease-free survival by investigator assessment in stage 2 to stage 3A patient. Key secondary endpoints were DFS in overall population, that is stage 1B to 3A, landmark DFS rates, OS, safety, health-related quality of life. Next slide. So this trial showed that ADAURA trial showed that it significantly the osimertinib arm had a significantly improved DFS compared to the placebo arm in both primary population as well as the overall population. So the study population of stage 2 to 3A osimertinib versus placebo, median DFS significantly prolonged, 65.8 months versus 21.9, and a hazard ratio of 0.23. Very rarely do we see that in adjuvant therapy we have such a wonderful hazard ratio. And in the overall population, which also included stage 1B, again the results were quite similar: 65.8 months DFS versus 28.1, and hazard ratio of 0.27. Again, statistically significant. The curves are separating very beautifully. Next. Now, what we see that the lung cancer has sensory site, most commonly the brain, and if we see that we are able to control the systemic disease, but the disease often reoccurs in the brain. So adjuvant osimertinib in this trial significantly improved CNS disease-free survival. So CNS metastases are a poor prognostic factor among patients with NSCLC and are associated with deterioration in quality of life. So osimertinib has shown greater penetration of the blood-brain barrier and higher exposure in the brain compared with other EGFR TKIs. Adjuvant osimertinib demonstrated CNS DFS benefit versus placebo in both the stage 2 to 3A as well as stage 1B to 3A population. So this was the JCO January 23 update. ADAURA updated CNS disease-free survival analysis. Stage 2 to stage 3A, osimertinib versus placebo, both CNS DFS was not reached, but it was significantly better with osimertinib, hazard ratio of 0.24. And as you can see, the Kaplan-Meier curve, they are even up to 60 months. There are very few events in CNS in patients who were on osimertinib. Next. Now coming to the safety analysis, we have been using osimertinib for long in metastatic settings. So no new adverse events was noted when compared to primary readout of ADAURA data. And grade 3 side effects were present in 23%, but less than 1% mortality due to these side effects. And 20% were any grade serious adverse events, and 13% led to discontinuation, while 12% had dose reduction and 27% had dose interruption. So again, grade 3 side effects only 11%, and no death due to which was causally related to adverse events. Next. So the key takeaway points are: in order to improve survival, we need to put more effort to identify lung cancers early. Never miss an opportunity to test for actionable mutation. This applies to early lung cancer also, especially for EGFR. And collaboration with multidisciplinary team is key to improve overall survival. And patient may ask for treatment options for best survival probability. Be ready to discuss and offer. Next slide. So patients may ask for treatment options for best survival probability and be ready to discuss and offer them as per the best data available. ADAURA data gives a probability of patient to remain cancer-free along with survival benefit. Being cancer-free is goal of patient as well as his or her treating physician. Thank you. Next slide.
Thank you, Dr. Priyanshu, for taking us through the adjuvant treatment. I hope you have started using osimertinib in the adjuvant treatment.
I've got a few tested done, but I have not yet got. I mean, post CTRT data is coming up, but the number of patients who are actually resectable in my practice are very few.
Very few.
So yeah, so probably with data coming after CTRT, and so I think that would be a major chunk in my practice. And I have not used as such the ADAURA protocol till now, because I've had a few resections and they have come out to be negative. I've used immunotherapy as adjuvant post resection.
Okay, thank you, Dr. Priyanshu.
Thank you, sir.
The next talk I will be taking, and it will be on advanced EGFR lung cancer. Dr. Kapil was supposed to take this talk, but somehow at the last moment his mother is not well. So I will be speaking on the advanced lung cancer FLORA data. So this is the optimizing treatment in advanced EGFR lung cancers. So we have already discussed EGFR mutations are approximately 40% in Asians, while they are around 20% in non-Asians. And the incidence in the Indian patients also varies between 20 to 23%. Most common is exon 19 mutation. This is followed by exon 21, and then followed by exon 20, then exon 18 and exon 12. So these are the first, second, and third generation EGFR TKI, and they are all not equal. Erlotinib and gefitinib are first generation EGFR TKI. They bind reversibly to the wild type and mutant EGFR, and they are inactive on T790M mutation, while afatinib and dacomitinib, they are second generation TKI, which are irreversible binder of EGFR, and they have broad activity to overcome our EGFR TKI resistant mutations, but not T790M. Osimertinib is a third generation EGFR mutant specific inhibitor. It has got specificity for T790M mutations, and it is an irreversible covalent binder of mutant EGFR. So this is the FLORA study, a randomized double-blind phase 3 study to assess the safety and efficacy of osimertinib versus standard of care EGFR TKI as a first-line treatment in patients with locally advanced or metastatic EGFR and NSCLC. So this we have already covered. There are three generations of TKI: gefitinib or erlotinib, which are reversible binder, afatinib, which is irreversible, and osimertinib is irreversible. And the most important thing is the ability to cross blood-brain barrier, which is maximum in the third generation EGFR TKI, that is osimertinib. So this was developed to selectively target both EGFR sensing and EGFR T790M resistant mutation. It was developed in such a way. It inhibits both EGFR mutations in exon 19 deletions and L858R as well as T790M mutation, while the binding with wild type EGFR is minimal. This is the FLORA study design. The patients, they were all locally advanced metastatic lung cancer, NSCLC, adenocarcinoma, and with exon 19 deletion or L858R mutation. EGFR TKI therapy was given in the form of osimertinib versus gefitinib or erlotinib, which is standard of care. And then these patients, they were followed every 6 weekly for the RECIST 1.1 criteria, and the crossover was allowed. Patient with confirmed progressive disease by independent committee review on standard of care and T790M mutation may begin post-progression osimertinib. And this is the PFS curve, which are widely separating, starting just from within the initiation of osimertinib. So PFS is a direct measure of drug benefit, and FLORA was powered for PFS. It is 18.9 months versus 10.2 months. And none of the subgroup, there was no subgroup which did not benefit from osimertinib as compared to the gefitinib. So all the subgroups in terms of age, sex, smoking history, CNS, metastasis, PS, or EGFR mutation status, they were actually favoring EGFR TKI osimertinib rather than gefitinib or erlotinib. And this is the overall survival, 38.6 months versus 31.8 months for standard of care. And the median overall survival is more than 3 years now. Osimertinib patients, they were more likely to be alive at 2-year and 3-year landmark. The first time an EGFR TKI has translated PFS to the significant overall survival benefit. So 28% of the patients, they were still receiving osimertinib at 3 years, and 28%, which was 3 times more than the comparator arm. You can see that it was 28% versus 9%, almost 3 times more. And time to first subsequent relapse was also more in osimertinib. It was 25.5 months versus 13.7 months in the comparator EGFR TKI. And in terms of PFS or overall survival across the subgroups, neither PFS nor OS favored first generation EGFR TKI. Both of them favored third generation EGFR TKI, that is osimertinib. So osimertinib PFS benefit was clearly maintained, consistent across all the subgroups, demonstrating its superior benefit across all the population, including race and across the different mutation. All overall survival subgroup showed that the positive benefit in favor of osimertinib, although the magnitude of the benefit varies. And this is consistent with PFS data in which subgroup favored osimertinib. So approximately 30% of the patient, they are eligible for osimertinib as a second line treatment following the progression. So, and you cannot predict which patient will develop T790M mutation. Only 50% of the patient who are alive, they will develop T790M mutation. So if you use EGFR TKI osimertinib in the second line, then the only 1 in 3 patient will be eligible for second line osimertinib, and hence it is prudent that we use this EGFR TKI osimertinib in the first line treatment rather than second line treatment. So only 60 to 70%, 80% of the patient can receive an accurate T790M result, and not all patients are able to receive valid T790M result upon rebiopsy. Plasma testing may yield false negative results. These are the summary of the rebiopsy results. You can see that in many of the clinical trial, the patient, they did not receive rebiopsy result, or it was falsely negative. So crossover rates and subsequent second line therapies for FLAURA in the experimental arm, 31% of the patient in the experimental arm could not receive second line treatment, and hence it is always prudent that we use osimertinib in the first line treatment. So approximately 1/3 of the patient did not receive second line therapy in the phase 3 clinical trials as well. So in a real world study of the patient with EGFR mutant NSCLC, risk of not receiving second line therapy is very, very high. And this was a retrospective study of 140 patients with EGFR mutant NSCLC in Germany to identify the treatment patterns. And 112 patients were candidates for second line therapy out of 114. And only 30% of these patients did not receive second line therapy. The reason for not receiving second line therapy was patient refusal and poor PS. And in these 70% patients, you see there will be just 50% T790M mutation. So across all the line of therapy, only 29% were treated with third generation EGFR TKI after the accessibility. And this is the real world data across multiple countries confirm that in clinical practice, only 1/3 or fewer patients, they receive second line osimertinib. So these are various studies, some of which show somewhat even less than 9% or 10% mark. So the treatment sequencing in the advanced EGFR and NSCLC survival with first generation versus first line versus second line osimertinib. I think it should be osimertinib followed by chemotherapy for all the patients. And if you use first line, then it is first generation EGFR TKI, then it is 10.2 months. Then if you use osimertinib, it would add another 10 months. And in fact, just 30% of the patient, they will receive osimertinib and then chemotherapy. So only 1/3 of the patient, they will receive osimertinib benefit. So the key message is the osimertinib is the only EGFR TKI which has demonstrated clinically and significant improvement in overall survival. FLAURA trial was the first trial to demonstrate EGFR TKI that has translated PFS into overall survival. Osimertinib got OS versus first generation EGFR TKI in the untreated EGFR mutant patient as well as T790M mutation patient who have progressed on the first line treatment. It is the only EGFR TKI to report statistically significant intracranial efficacy. It is tolerated at recommended dose of 80 milligram. Adverse events leading to dose reductions are very less as compared to the second generation EGFR TKI, and sequencing cannot be considered as a best strategy, as 70% of the patients, they are not eligible to receive osimertinib in the second line. So you can see the osimertinib, it has been given as a preferred first line treatment in the NSCLC, which is mutant EGFR mutation NSCLC. Thank you so much for your patient listening. So the next talk is by Dr. Praveen, and Dr. Praveen is a senior consultant and head at Akash Institute. Dr. Praveen is here.
Yeah, hi, Dr. Manish.
Hi, Dr. Praveen.
Good evening.
So we'll be speaking on the exceptional response to osimertinib in EGFR mutant metastatic NSCLC. Welcome, Dr. Praveen.
So thank you, Dr. Manish, for giving me this opportunity. I hope my screen is visible.
Yes.
Yes, sir.
Yes.
And I'm audible too?
Yes, sir.
Yes.
So, okay. So thank you, Dr. Manish, for giving me this opportunity. And I'll be speaking on an exceptional response which is seen to osimertinib in EGFR mutated metastatic non-small cell lung cancer. And these slides have been provided by AstraZeneca, and the case also is from AstraZeneca. It is not my case. So to begin, in October 2020, Mr. X, who is a 64-year-old gentleman, he presented with complaints of coughing, progressive breathlessness, and severe backache. So with these complaints, so he was not able to walk without support since last 10 days, and the giddiness is there since last 5 to 6 days, and weight loss of 5 kg. So all of these things, so they are pointing towards a systemic kind of illness, which is involving the lung, which is involving the brain. So patient also has a constitutional symptom in form of weight loss, and patient was non-smoker. So the patient was evaluated further, and after initial evaluations, so he was diagnosed to have a lung mass, and for staging purpose, the PET CT scan was done, which showed a mass in the right upper lobe. So with hilar lymph nodes of size 41 into 32 millimeters and multiple bony metastases. We can see over here, so there is a right upper lobe mass, and along with that, so we have multiple bony metastases. So to confirm the diagnosis, biopsy was done from the lung mass, and it was suggestive of adenocarcinoma, and the histology confirmation was taken with immunohistochemistry, and the patient was bookish way TTF1 positive, NAPSIN positive, and the patient was negative for P40, and thus the diagnosis of adenocarcinoma of lung primary origin. So it was confirmed, and the patient further underwent molecular analysis on the FFPE, and it was found that EGFR exon 19 mutation was present, and apart from that, other targetable mutation in form of KRAS, BRAF, HER2, MET, exon 14 skipping mutation, ALK and ROS. So they were negative, and PDL1 was also performed, so which was also negative. So with this molecular analysis, so the final diagnosis was EGFR exon 19 mutation positive non-small cell lung cancer, where the metastasis is there in the bones. So as a part of staging workup, so MRI brain was also done, as patient was also having neurological symptoms, and we can see over here that there were multiple ring enhancing lesion in cerebellum and cerebral hemisphere, and there was significant perilesional edema. So we can see over here, so it was there were bilateral lesion, and there was bilateral very ominous looking cerebral edema was there, and we can see over here in these images that there is a lesion along with the perilesional edema. We can see over here the black one is a perilesional edema. So with these, the final diagnosis was stage 4 non-small cell lung cancer, exon 19 deletion, mutation with bone and brain metastasis. So whenever we come across such a situation, so we always look at whether the patient is symptomatic for brain metastasis. If the patient is very much symptomatic for brain metastasis, so conventionally we go ahead and do radiotherapy or local therapy for the brain metastasis, and after that we usually start with the EGFR TKI based treatment. So here also, so the same was considered. A local radiation therapy for metastasis was given, and after that, EGFR TKI to target exon 19 deletion mutation was started. So now we have uh, various options here. So we have option of first generation TKI, we have option of second generation TKI, and we do have option of third generation TKI. Apart from that, there are other strategies also, like combining uh, TKI with chemotherapy, combining TKI with VEGF directed therapy. So these all options are there with us. So looking at TKI only options, so first generation TKI, they have consistently given a PFS of 9 to 11 months. The second generation TKI, they have given 11 to 14 months of PFS. And the third generation TKI, osimertinib, which was studied in FLORA trial, it had given the median PFS of 18.9 months. So these are the bar charts which shows the median PFS which was observed in all these trials. And so, few slides about the CNS penetration of osimertinib, because we are dealing with a case who have a good amount of disease burden in brain. So, it is seen these were the mouse brain concentrations which were seen after administration of osimertinib and gefitinib and afatinib, and we can see over here that the Cmax, the plasma Cmax, it was 0.82 and 0.82 for gefitinib, osimertinib, and it was 0.14 for afatinib. But if we look at the brain maximum concentration, so it was highest for osimertinib, so much so that it was almost 18 to 20 times that of gefitinib. And if we look at the brain to plasma Cmax ratio, so it was 3.41 in osimertinib. That means the brain concentration of the drug was almost 3.5 times that of plasma concentration. And if we look at the gefitinib, so the brain concentration was only 20% of what the plasma concentration was. So this was a phase 1 study, and this was performed in healthy volunteers. So here what was done was that this radio labeled or C11 labeled osimertinib was given to these 8 subjects, and these were healthy subjects. They were not having any lung cancer or brain metastasis. And in these patients, a PET scan was done, and it was seen that all of these patients, they had good amount of CNS concentration or CNS penetration of osimertinib, and we can see over here that so all of these images, they showed the CNS penetration. And one more thing which was seen was, so it was more of a gray matter concentration rather than the white matter concentration. So this was again a phase 1 study where the C11 labeled osimertinib was given to the patients. So these were the 2 patients, and this abstract was presented in WCLC in 2019. And these were 2 patients who were subjected to osimertinib, and PET scan was done at the baseline. Pre-dose PET scan was done, and then the PET scan was done on the day 2 of the dosing, which was 6 hours post single osimertinib 80 milligram dose. And there was another third PET scan which was done 21 days later, when osimertinib as a single agent was given for 21 days, and the PET scan was done after that. So we can see over here in both the images that there was a progressive progressive concentration of osimertinib in the brain. If we look at the first image and the third image, so there is a huge difference. So in early post 6 hour also the concentration was high, and here also we can see this is the baseline scan, and at 6 hour there was good concentration of osimertinib. But if we look at the 22-day PET scan, so there is huge amount of osimertinib accumulation in the brain. So depending on these studies, so it was seen that probably the osimertinib is a drug which is more effective for brain metastasis, and it was proven in FLORA trial also, which we'll be looking in subsequent slides. So these are usually the treatment protocols which we follow. So those patients with newly diagnosed EGFR positive non-small cell lung cancer who have brain metastasis, so we always look at the symptoms. So if the patient is symptomatic, we go ahead and give local therapy to the patient. Excuse me, sorry. So the local therapy is in form of surgery if there is a dominant lesion, or if the lesion is there at a critical place, and if there is only one or two lesions, so we can go ahead with the surgery, and post that radiotherapy option is also there. But if there are multiple lesions, or if there are small lesions which we can go ahead and do with get away with SRS, we usually do SRS followed by the TKI. So, but if a patient is symptomatic and there are multiple brain metastases, again we have two options. If the patient is willing for osimertinib, we can explain it to the patient that we can monitor the patient on osimertinib, because the response rates, the CNS response rates with osimertinib is also close to 70%. And if we look at the radiation responses, so they are also close to 70%. So we have two options, either to go ahead with osimertinib, or we go ahead with radiotherapy. If we are going ahead with osimertinib, we have to keep a close follow-up on the patient, close watch on the patient, and at a time of progression or worsening of symptom, we can go ahead with the radiotherapy. But as such, guideline recommends if there are symptomatic disease, we should go with the local therapy first, followed by TKI. So those patients who had a progressive disease post first generation or second generation TKI in the first line, so then we again look for the symptomatic brain metastasis, and whether it is oligometastasis or a extracranial and cranial metastasis, both progression both. So if there is oligo progression, we just go ahead with the local therapy, and then we continue with the first generation or second generation TKI. But if the patient is having a poly progression or multiple progressive sites are there, so then we go and see whether the patient is having T790M mutation or not. If the T790M mutation is there, we go ahead with the osimertinib. If T790M is not there, then we go ahead and do the chemotherapy. So these are the treatment algorithm which we follow in our clinical practice. And this we were talking about FLORA trial and the brain outcomes. So we can see that so the orange curve is of osimertinib and the green curve is of SOC. And there are two different graphs. So one is with those patients who had CNS metastasis at baseline, and the second chart, right chart, is in those patients who did not have any baseline brain metastasis. So we can see over here in both the groups, osimertinib, it had a significantly better median PFS as compared to the standard of care. In those patients with brain metastasis, baseline brain metastasis, the hazard ratio was 0.47, and if we look at those without brain metastasis, hazard ratio is 0.46. So the quantum of benefit which the patient got with osimertinib, it was irrespective of whether there were brain metastasis at baseline or not. So these are various trial put together in a table to look at the brain metastasis, brain outcome rates. So afatinib, so there were two studies. So one was the LUX-Lung 3 or 6 study, so which compared afatinib with the chemotherapy, and LUX-Lung 7, which compared afatinib with the gefitinib. And both of these study, they had included patients with brain metastasis who were asymptomatic. And we can see over here that the median CNS PFS was 8.2 versus 5.4 month in favor of afatinib. And but if you look at Lux Lung 7, where gefitinib was used in the comparator arm, so there was no significant advantage which was seen with afatinib as far as CNS PFS was concerned. So coming to dacomitinib, so they did not include any patients with brain metastasis. So we still do not know how is the activity of dacomitinib in the brain. So looking at osimertinib, FLORA trial, again 116 patient, they had asymptomatic CNS metastasis at baseline. And if we look at the systemic response, so it was 15.2 months versus 9.6 months as far as the median CNS PFS is concerned. And it was statistically significant. If we look at the CNS response rate, it is 66% versus 43% with the comparator EGFR TKI. So coming to our patient, so for bone metastasis, palliative radiotherapy to spine for backache was considered along with zoledronic acid. Patient refused for brain radiotherapy and wanted to observe with that, and as patient was willing for osimertinib, and patient was started on osimertinib. If we look at 4 months post osimertinib scan, so this was the right upper lobe lesion initially in October, and if we look over here, so it is almost disappearing. And if we look at the bone metastasis also, so they also were better, and there was a reduction in right hilar and paratracheal lymph node size also. So over here, if we look at the measurable disease, so there is a partial response as per the RECIST criteria. So effectiveness of TKIs in brain metastasis, again, we can see over here that the FLORA trial showed that the CNS overall response rates, so those were 66% with osimertinib as compared to 43% with erlotinib. But if we look at those patients who had measurable disease, so they were more responses with the osimertinib as compared to the EGFR TKI first generation. So these were the follow-up MRI scan, and we can see almost complete response in brain. So this was in July 2021, and there was complete resolution of brain metastasis on MRI brain. And so after complete remission, so no additional intervention was needed for the patient. So another case study. So a 53-year-old patient who, while he was on treatment for stage 3A disease with chemotherapy, so the patient developed reoccurrence. The patient had local recurrence. Apart from that, brain MRI also showed multiple brain metastasis, and the patient was found to have EGFR del19 mutation, for which osimertinib was started. And we can see over here, so this was the scan, initial scan, day 0, day 15, you can see the mass lesion reduced, and there was complete resolution of lesion in subsequent scans. So this was again a case report. So this again showed that there was a 74-year-old woman, so who had left upper lobe mass with multiple bilateral lung metastasis, and there were asymptomatic multiple brain metastases also which were noticed. And osimertinib was started for this patient as she was EGFR mutated. So after 5 weeks, the multiple brain metastases, they disappeared completely together with the response in lung lesion. And this again reiterated the fact that the responses, CNS or the systemic responses with first line osimertinib, so they are great. And these patients, they can very well get away with radiotherapy toxicity if the patient understands that there are slight bit of chances of progression on osimertinib, and if they do not do well, so at that point of time radiotherapy can be considered. So this was another study which demonstrated efficacy in CNS metastasis, and it was a phase 2 open label 3-arm prospective study, and these patients were either treatment naive or they were previously treated with an EGFR TKI, and the third group was where the EGFR was negative. And we can see over here that the overall response rate, those were maximum 84.2% with the treatment naive patients, 66.7% with the previously treated patient, whether or not they had T790M positivity, and 50% in those patients who were T790M negative, who were previously treated with EGFR TKI. So this suggests that probably there is a different clone of EGFR which is seen in the systemic progression and the cranial progression. So that is the reason why osimertinib given even after failure of first generation or second generation EGFR TKI who did not had a resistance mutation as T790M, so they also did well with osimertinib. So this was our case study. So we can see over here that the patient was maintaining complete response at April 2022 scan also. So to conclude, radiotherapy for brain is not needed in all the patients, and this patient refused for radiotherapy, and still the patient had complete resolution of brain metastasis. There is almost complete resolution of primary disease and nodes. So there are no adverse events significant which are reported in this patient, which are different from the clinical trial. So patient remains progression free even after 19 months of initiation of osimertinib, and the patient is presently asymptomatic, fully active, goes for morning walk, yoga session, leading a normal life. So with this, I would like to end my talk. Thanks for patient listening. And if there are any questions, I think we can take up right now. Thank you.
Thank you, Dr. Praveen. That was excellent talk. So these reports, they indeed show the exceptional response to EGFR TKI. And the next talk I will be delivering upon the reimagining the CNS metastasis. Can I share my screen?
Yeah, sure, sir.
So these are reimagining CNS mutations in EGFR mutant advanced lung cancer, how the treatment compare. So incidence we have already discussed. 85% is NSCLC and 15% are small cell lung cancer. And in NSCLC, the major chunk is EGFR mutation. Others are ALK-ROS, MET, BRAF, NTRK, G12C, etc. So today we will speak about the non-small cell lung cancer, which is EGFR mutant, having brain metastasis. So the incidence across the world is somewhere between 15% in the Europe to 62% in Asia. And in India, approximately the EGFR mutation incidence is 25 to 30%, as we have already seen in the previous slides. And the patients with the lung cancer, they have highest rate of identified brain metastasis. And such incidences, they are more pronounced in EGFR mutant lung cancer. So this was one of the study, and at the final follow-up, 44% of the patient with EGFR mutation tumor, they had brain metastasis, compared with 22% of the patient with wild type EGFR. And leptomeningeal metastasis has poorer prognosis when not treated. The actual survival is within weeks, that is 4 to 6 weeks. And the leptomeningeal metastasis may be more frequent in patients with EGFR mutant and SCLC as compared to the wild type EGFR mutant, non-mutant NSCLC. So approximately 10 to 20% of the NSCLC patient, they have brain metastasis at the time of presentation, and approximately 40% will develop brain metastasis during the course of the disease. And you see the brain metastasis leads to the poorer quality of life as compared to the other metastatic disease such as adrenal gland, liver, contralateral lung, bone. If there is a brain metastasis, then there is a decline in the quality of life. Patient with a single brain metastasis experience the greatest decline in the quality of life as compared to the other metastasis. So the brain is a sanctuary site for invading metastatic tumor as it is protected by blood-brain barrier. Up to 40% of the patient with non-small cell lung cancer with EGFR mutations will develop brain metastasis. EGFR TKI are also substrate for human blood-brain barrier efflux transporter to varying degree, and this influences the distribution of the compound in the brain at equilibrium. And hence it is imperative that EGFR TKI must have a good brain exposure so that they can achieve the best intracranial efficacy. And these are the diagrams which were explained by Dr. Praveen. And this is osimertinib differentially penetrates the intact blood-brain barrier. You can see the different oral TKI, and the maximum penetration is by osimertinib in the brain. This was also discussed by the previous speaker, and you can see that the osimertinib and gefitinib, when they have similar plasma concentration Cmax of 0.82, the brain concentration is 2.78 versus just 0.717 in the gefitinib micromole per liter. And you can see that the brain plasma Cmax ratio is 3.41 versus 0.21 in osimertinib versus gefitinib. So these are all studies on animal to show that the osimertinib has the highest brain penetrance. And on the right hand side, you can see the whole brain radioactivity following administration of microdoses labeled EGFR TKI to monkey. And the data, it is corrected for the radioactive decay, and the maximum concentration is seen in the osimertinib. Osimertinib causes tumor regression in EGFR mutant tumors which are metastatic to the brain. And this is the osimertinib was homogeneously distributed in all the regions of the brain in the healthy volunteer. This is the diagram which Dr. Praveen also showed. There are different subjects in which the individual regional distribution of osimertinib was shown in the healthy volunteers. And this was also covered. So osimertinib binds irreversibly to the clinically relevant mutant EGFR kinase forms, that is L858R, exon 19 deletion, T790M mutation, to selectively inhibit mutant EGFR kinase activity. Prolonged PFS and OS related to the first generation EGFR TKI exhibited anti-tumor effects in patients with NSCLC harboring various EGFR mutations, common and uncommon, high blood-brain barrier penetration, and brain exposure related to the other EGFR TKI, and is active against CNS metastasis. It inhibits the growth of CNS metastasis in patients with EGFR mutant positive NSCLC. So how does efficacy of osimertinib compare to the first generation oral TKI in the treatment of NSCLC with EGFR mutations? This was the FLORA trial. This was the FLORA trial in the EGFR positive metastatic NSCLC, previously untreated osimertinib as a first-line treatment, where the patients, they were randomized into osimertinib versus standard of care. All of these patients, they had EGFR mutation stage 4 adenocarcinoma of lung. And the various assessment points were June 2017, and then final assessment was done in June 2019 after 321 deaths. And you can see that the median PFS was 18.9 months versus 10.2 months. Hazard ratio was 0.46, and median overall survival was 38.6 months versus 31.8 months for comparator EGFR TKI with hazard ratio of 0.80. And the PFS is a direct measure of the drug benefit. And in patient with the known or treated CNS metastasis, median PFS was 15.2 months versus 9.6 months in the FLORA trial. And the osimertinib had significantly lower overall survival as compared to the EGFR TKI. And at 24 months, 74% versus 59%. And at 36 months, 54% versus 44% patients, they were alive. This is the final result and the CNS analysis. Those patients with known CNS metastasis, the osimertinib had median PFS of 15.2 months versus standard of care, which was 9.6 months. And without known or treated CNS metastasis, it was 19.1 months versus 10.9 months. Hazard ratio was 0.46. So CNS progression event occurred in 17 patients receiving osimertinib versus standard of care. And in FLORA trial, osimertinib demonstrated superior systemic PFS benefit regardless of CNS disease status at the study entry versus EGFR TKI comparator arm. So this is full set analysis. 61 patient in osimertinib arm versus 67 patient in the comparator EGFR TKI. They had a brain metastasis. CNS PFS was not reached versus 13.9 months in the comparator EGFR TKI. Overall responses were 66% versus 43%, and the odd ratio was 2.5. And this is CNS full set analysis. The median CNS PFS was not reached versus 13.9 months. Hazard ratio was 0.48 at the median follow-up of 12 months and 7 months in the standard of care arm. So CNS PFS was statistically significant with osimertinib versus comparator arm. CNS progression by blinded independent committee review also occurred in 20% patient versus 39% patient. And this is not only treats, but also prevents. So those patients who did not had CNS disease, only 20% patient, they progressed in osimertinib arm, while 39% patient progressed in the EGFR TKI arm. So this is the FLORA trial results. Patient continuing to receive first-line trial drug. We already discussed at 3 years' time, almost 3 times more patients, they were receiving the trial drug. That is 9%. So the first line osimertinib may delay the need for subsequent therapies, and 28% patients versus 9% patient continue to receive first line drug at 36 months. So coming on to some real world.
Your slide is not visible.
Now?
Not now, sir.
Is it visible now?
No, sir.
My screen is visible?
Not, sir.
Is my screen visible now?
No, sir. Can you please share again?
I have already shared. So can you share the screen?
Geetika, you can share that slide from your side.
Okay, can you please confirm your page number, sir?
So it was page number 21, slide number 21.
Okay, sir, just wait. Sir, it is visible?
Yes. So the CNS progression by independent committee review in 20% patients versus 39% patient in the comparator EGFR TKI. So this drug not only treats but also prevents the progression in the brain. Next slide. Next slide. Yes. Next slide. So these are the FLORA results. We have already covered. Next slide. Next. Yes. So coming on to the some real world evidence of osimertinib with CNS metastasis. Next slide. So this is one of the case report, two case reports, in fact, rapid intracranial response to osimertinib without radiotherapy in non-small cell cancer patients harboring EGFR T790M mutations. Next slide. So this is case one. Next slide. Next slide. So this is the case description. Patient underwent right middle lobe resection of the lung because of an early stage NSCLC 9 years ago, and multiple nodules emerged in both the lungs at 7 years ago, which was recognized as a recurrence. Identified EGFR mutation L858R in exon 21. Gefitinib was administered as first-line chemotherapy for 2 years, 11 months, and after 3 lines of cytotoxic treatment, that is pemetrexed and carboplatin, Tegafur, Gemcitabine, Otaracil, plus bevacizumab and docetaxel, erlotinib was administered as a fifth-line chemotherapy, which failed in 3.5 months. And after 2 courses of vinorelbine administration as a sixth-line chemotherapy, patient complained of unbearable back pain, and spinal MRI detected multiple thoracolumbar bone metastasis. Radiotherapy was conducted to control the pain and prevent fracture. Bronchoscopy had also been conducted to rebiopsy, and it detected T790M mutation in exon 20. At 7th line of the treatment, osimertinib was administered. From the next day, brain nodules were detected when the PS of the patient was PS3. Next slide. And you can see there were multiple brain nodules in MRI pre-treatment, and the post-treatment day 13 shows the clearance of the complete remission of the brain metastasis, except for one in the frontal region after 13 days. And there is shrinkage of the right pulmonary nodule after 5 days of the osimertinib administration. Next slide. This is case number 2. Next slide. So this was 76-year-old male with 22.5 pack year of smoking history and underwent right upper lobe resection of the lung because of the early stage NSCLC 10 years ago. EGFR exon 19 deletion was present. Multiple bone metastasis as recurrence emerged 6.5 years ago. Gefitinib was administered first-line chemotherapy for 4.5 years. Afatinib was administered for 10 months after sandwiching the 4 course of carboplatin plus pemetrexed with bevacizumab. While fourth-line chemotherapy, Tegafur, Gemcitabine, Otaracil was being administered, pleural effusion started, and the thoracocentesis was conducted, and the final mutation was detected, which was T790M mutation, and the osimertinib was administered as a fifth-line chemotherapy when the PS of patient was PS2. Next slide. So on day 10, after the administration of osimertinib was started, brain CT scan images revealed remission of the single brain metastasis at the right parietal lobe, which was symptomatic. On day 14, decrease of the pleural effusion and shrinkage of the pulmonary nodule were noted, apparently on the chest X-ray. After a month, CT scan images revealed shrinkage of the multiple lung metastasis and decrease of the left pleural effusion. His PS gradually improved to PS1, and there was a decreased pleural effusion. Next slide. So you can see the observation pre-treatment and day 10 of the osimertinib administration. There was complete remission of the single brain metastasis that was present after 10 days of the osimertinib treatment. Next slide. And you can see there was a decrease in pleural effusion after 14 days. There was shrinkage of pulmonary nodule. And after 31 days, the shrinkage of multiple lung metastasis can be seen, and decrease in the left-sided pleural effusion can be seen. Next slide. This is another case, case number 3, complete remission of multiple brain metastasis in patient with EGFR mutant NSCLC treated with the first-line osimertinib without radiotherapy. Next slide. So this was 74-year-old lady with no history of smoking and elevated blood carcinoembryonic antigen levels. The CT scan revealed 40 millimeter shadow in the upper lobe of the left lung and multiple bilateral small nodules in the entire lung field. Diagnosed with T4N1MC stage 4B lung adenocarcinoma with EGFR mutation, exon 19 deletion mutation, and more than 20 multiple asymptomatic brain metastasis, and the maximum diameter was 12 millimeter were detected by MRI. And these were asymptomatic brain metastasis. So osimertinib was administered at 80 milligram once a day and was administered as a first-line treatment. WBRT was deferred. Next slide. And you can see that this is the CT scan of the lady, 40 mm wide shadow in the upper lobe of the left lung, we can see, and the multiple bilateral small nodule in the entire lung field we can see. Next slide. And there were multiple brain metastasis with maximum diameter of 12 millimeter detected at the first diagnosis. And after 5 weeks, the multiple brain metastasis, they had disappeared completely. You can see the upper slide deck and the lower. In the upper, you can see there are multiple, at least 10 to 12 brain metastasis. In the lower MRI films, you can see there is complete CNS response, which was confirmed. Next slide. This was a cohort study, intracranial outcome of de novo brain metastasis treated with osimertinib alone in the patient with newly diagnosed EGFR mutant NSCLC. Next slide. So this was the retrospective cohort study. Patient was selected from institutional database, and if they had the diagnosis of EGFR mutant NSCLC and treated with osimertinib between 2014 and 2022, received osimertinib alone as initial therapy after first brain metastasis diagnosis, and had at least one intact brain metastasis not previously treated with systemic or local therapy, that is SBRT or whole brain radiotherapy, at osimertinib initiation, and had baseline brain metastasis, brain imaging of MRI before and after, or after at least one scan after the osimertinib. So the median age at the brain metastasis was 64. 72% patients, they were female. 69% they were non-smoker. 94% patients they had stage 4, and PS was 1 to 2 of most of the patient. 11 plus brain metastasis, they were present in 36 patients. 6 to 10 brain metastasis present in 22 patients. 2 to 5 brain metastasis present in 22 patients, and single brain metastasis present in 19 patients. Neurological symptoms from the brain metastasis present in 50% of the patient. And extracranial status at the time of the brain metastasis diagnosis, additional to extracranial metastasis, were 86% patient. Next slide. And you can see the multiple observations, baseline study, where you can see multiple brain metastasis, pre-osimertinib scan at 2 months, osimertinib scan, you can see the regression of the disease which is observed, and at 34 months post-osimertinib, you can see disease control was still until 34 months of the osimertinib treatment. Next slide. So there were 36 patients who had median interval from brain metastasis diagnosis to first line osimertinib initiation of 25 days. In total, 136 previously untreated brain metastases were tracked from the baseline, and overall 105 lesions had complete response, that is 72%, 77% patients had complete response, and 31 patients they had partial response from the baseline brain MRI. This reflects the best objective response rate of 100%, and 2-year overall survival rate was 80%. CNS progression rate was at 1, 2, and 3 years post-osimertinib was 21%, 32%, and 41% respectively. And the lesion level local failure was estimated to be 0.7%, 4.7% at 1 and 2 year post-osimertinib respectively. Next slide. Next slide. So what are the recent guidelines and updates suggest? Next slide. Next slide. So recent NCCN guidelines suggest osimertinib as a first-line treatment in exon 19 deletion or L858R mutation patients. And this is category 1 and preferred treatment. Next slide. Thank you for your patient listening. If there are any questions, we can take a few questions.
So is there any questions?
So if there are no questions, we can close the meeting. Thank you for joining. Good night.
Thank you. Thank you very much, sir.
Thank you.
Thank you so much, Manish sir.
Thank you, Kritika. Thank you, everyone, for joining.
Yeah, thank you, ma'am.
Good night. Bye.
Should I close the session?
No, please wait. Can you please close the meeting? So tech support.
Hello.
Yes, Akash, can you please close the meeting now?